So mainly patients with Hodgkin lymphoma in advanced states have a poorer prognosis than those ones that are diagnosed in initial stages, and their overall survival at 5 years is around 60 to 70%, when in the initial stages patients are mainly cured. So they are around 80-90% of overall survival at 5 years. There's another handicap in these patients that when they are old, they cannot receive standard care chemotherapies, so they are normally not treated correctly or with the normal doses of chemotherapies that we need to give, and that makes that these patients have a lower survival than younger patients. The rationale for this clinical trial using nivolumab, that is an anti-PD-1 immune checkpoint inhibitor, combined with adriamycin, vinblastine, and dacarbazine, is mainly to try to higher the numbers of complete responses in these patients. We have seen that checkpoint inhibitors in Hodgkin lymphomas give overall responses that are around 70% when they are used in monotherapy. So it was a good idea to try them to combine them with the standard care chemotherapy in first line in patients with advanced stage disease to try to increase the progression-free survival, the overall survival, as well as the complete metabolic responses. So the main findings of this Cohort D CheckMate 205 clinical trial after 24 months follow-up was that the overall response rate of these patients was 86%, with a 75% of complete metabolic responses when assessed by the DeVille scale. This is an increase of almost 15% from what initially was presented using the 2007 TISON classification, or to evaluate complete response, and this makes that the concordance between what the independent review committee and the investigators found at the end of treatment is higher. On the other hand, we see that progression-free survival at 21 months is 83%. That is a very high progression-free survival for this type of patients with advanced Hodgkin lymphoma, and in a cohort of patients that are aged up to 87 years, that is very old cohort, and also for patients that have bad prognosis, because most of them had B symptoms, had bulky disease, or had extranodal involvement. So I think that there's no contraindication, formal contraindication to use this regimen, because toxicity and all the safety profile is quite good, so you really can use it in all the patients. I think that I would really use them in advanced stage lymphomas, Hodgkin lymphomas, because in the initial stage Hodgkin lymphomas we have very good results already with ABVD. So probably I won't use this combination in first line in initial stages. But I think that probably older patients that cannot receive standard care bleomycin are one of the candidates to be using this type of strategies, and also those patients with advanced stage disease that have poor prognosis factors like extranodal involvement, or maybe bulky disease, or maybe B symptoms associated to the advanced stage disease, because the safety profile is very correct, and we have not seen any immune adverse events that really makes us have an alert about this protocol. So patients that receive nivolumab can go to an allogeneic stem cell transplantation, but we have to focus that this is a first-line treatment, and normally Hodgkin lymphomas don't receive allogeneic transplant in first-line treatment nor in second-line treatment. We normally use autologous stem cell transplant in second line, not in first line, and the allogeneic transplant is normally used after the autologous stem cell transplant or after third-line therapy. But I think, yes, you can use nivolumab as bridge to an allogeneic transplant, but you have to be aware that maybe you have a higher incidence of acute and chronic GVHD, and not only the incidence, but the severity or the relapse after first-line treatment of this GVHD. So you have to be aware of this increased risk of GVHD, but I think it's a good drug to do a bridge to an allotransplant.